Um, Greetings from Greece. This is Dr. Bampali. It's a pure honor to participate in this international congress. My presentation is about the optimal antithrombotic therapy after transcatheter valve intervention, concluding that the less the merrier, not only about the number of the drugs, but also about the duration of the therapy. I have nothing to disclose. Once upon a time, life was similar. You had the mechanical valve and you were going to give vitamin K antagonist, or you had the tissue valve and you are going to give aspirin. But then things get complicated because in 2002, Alain Gribier performed the first transcatheter aortic valve implantation. And in 2011, FDA approved the first TAVI as a treatment for severe symptomatic AV stenosis in patients with high surgical risk. Actually, this year was the 20th anniversary from the first TAVI. In 2019, the indication expanded to low-risk patients, and in 2022, the indication was even expanding to aortic regurgitation gradually with the Jena valve. On the other hand, in 2013, FDA approved the first transcatheter mitral valve repair, and 6 years later, approved MitraClip, which is transcatheter edge-to-edge regurgitation therapy for treatment of severe MV regurgitation in high surgical risk patients. We now await for approval for other devices about the tricuspid valve regurgitation, such as TriClip and TriCalv, and we have many data evolving about what we have to do when we have valve deterioration, and we must put a valve in ring, or a valve in valve. So now we have a new world with new devices. Besides the optimum procedure, the crucial factor is the optimum antithrombotic therapy, since there are single devices with intrinsic thrombogenicity. Also, we have new challenges because we have to combine therapy in patients who have also coronary artery disease or atrial fibrillation, and we have new drugs. We have now more potent PTY12 inhibitors such as ticagrelor and prasugrel, other than aspirin and clopidogrel in the past, and we have DOACs instead of VKA. The knowledge arises from the care guidelines and the landmark RACTs, especially from the latest guidelines from the European Society of Cardiology in 2021 for valvular heart disease. We have many antithrombotic agents. We have antiplatelets and anticoagulants in patients that may have more than 2 comorbidities. So the balance between bleeding and thrombosis is very crucial. The management of combined thrombotic therapy depends on the valve type and the thesis, the presence of AF, the presence of coronary artery disease, and the clinical status, if it is only a stable coronary artery disease or acute coronary syndrome with stenting, the bleeding profile of the patient, the GFR, the frailty, and of course the level of evidence. We know that when we have to combine antithrombotics that act in different pathways, the bleeding risk increases exponentially. In direct registry in 2019, with more than 1,500 patients, we saw that when you have to combine DOAC with antiplatelets, the bleeding risk, if it is even if it is major, is increasing. Of course, in this registry, there were only data about aspirin, clopidogrel, small data about prasugrel, and no data about ticagrelor. So chapter 1, we have TAVI. TAVI actually have the best level of evidence for guidelines. If you have no other indication for anticoagulants such as atrial fibrillation, then the recommended therapy is lifelong single intravascular therapy with evidence 1, a level of evidence A. If you have other indications such as for anticoagulation such as atrial fibrillation, then you have to give OAC since day 1, lifelong, as monotherapy. And the routine use of OAC is not recommended anymore after TAVI in patients with no baseline indication for OAC. So these guidelines focus on simplicity and monotherapy. If you have to give OAC, then prefer DOAC over VKA. If you have to give antiplatelet, then prefer aspirin over clopidogrel. And this is different because until 2017, the guidelines suggested that you should give dual antiplatelet therapy, which means aspirin and clopidogrel for 3 to 6 months if there was no atrial fibrillation. But this has changed now with focusing on monotherapy. What led to these simplified guidelines? For many years, we thought that TAVI were assumed to be like a big stent and react like that. So the intrinsic thrombogenicity will be similar to coronary stents, even though the device was exposed to higher velocities and pressure gradients. We also know that in up to 30% of the TAVI patients have pre-existing atrial fibrillation. Also, the last 5 years, there was an extended literature about the presence of subclinical leaflet thrombosis, mainly indicated by CT angiography, that set the indication that maybe we should give prophylactic anticoagulant therapy, even if the patient has no atrial fibrillation. That led to a lot of clinical trials, landmark that changed the philosophy of anticoagulants. If you have no indication for OAC, the popular TAVI study, cohort A, showed that single antiplatelet therapy is safer than dual antiplatelet therapy. A few years later, Galileo stopped prematurely because it was a game changer trial, because it showed that there is no place for prophylactic dose for prophylactic prescription for DOAC for subclinical leaflet thrombosis, because you have more bleedings, thrombosis, and death. If you have also atrial fibrillation, then popular TAVI cohort B showed that OAC, mainly VKA, plus clopidogrel cause more bleeding than OAC monotherapy. In the Atlantis trial, it shows that there's no difference between apixaban or VKA regarding thrombosis, but it is worse regarding bleeding. And finally, in the Investigate TAVI-F trial, it showed that there's no difference between doxaban and VKA antagonist, but if you have to combine with antiplatelets, then you have more bleeding in the stratum of doxaban. So, to sum up, if you have a TAVI plus atrial fibrillation, then you have to give DOAC over VKA lifelong. If you have a TAVI plus coronary artery disease, you have to separate. If the status is acute coronary syndrome with a stent, it's 6 to 12 months of dual antiplatelet therapy, mainly clopidogrel, because there are only few data about potent PTY12 inhibitors. And if you have a stable coronary artery disease, then it is lifelong SAP and mainly aspirin. But if you have TAVI plus atrial fibrillation plus an acute coronary syndrome, then the suggestion is less than 1 week of aspirin, max to 1 month if the coronary syndrome is a STEMI, plus 6 months clopidogrel if you have a recent standing in stable coronary disease, or 12 months if you have an acute coronary syndrome, plus lifelong OAC, which could be vitamin K antagonist or DOAC. Chapter 2 is transcatheter mitral valve repair. These devices gained a lot of attention at first, but then it stopped. They have increased thrombogenicity because you have more metal in the annulus. The type of valve affects the thrombotic risk. It's worse with the tenting valve. The approach also plays matter because transapical puncture is worse than transfemoral. There are no randomized clinical trials, only registries which only examined VKA with higher INR target 2.5, plus minus aspirin for at least 3 to 6 months, irrespective of atrial fibrillation, and then aspirin lifelong. And there is no data for DOACs. More sophisticated devices for mitral regurgitation is mitral clip. It has lower thrombogenic risk in the early post-procedural period. We have only extrapolated data from several devices. And so the first trials were designed with a regimen of 325 milligrams aspirin daily for 6 months up to 1 year, plus clopidogrel for 1 month. But that was the original design of the trials. But they show that there is a 22 increase of the bleeding post-procedure, so the recommendation changed to a more friendly therapy. So now we assume that mitral clip is a subtype of repair with, which carries a 30-day stroke risk up to 2.6%. If you do not have atrial fibrillation, then the therapy is aspirin plus clopidogrel up to 6 months, or 1 month VKA as per mitral valve repair with guideline 2A, a level of FDC, and then aspirin lifelong. If you do have atrial fibrillation, then it is lifelong VKA because we have no data for DOACs. Notably that in COAP trial, which was the mother trial for mitral clip, only 16% of the patients received DOACs. Another important issue is that if you have valvular atrial fibrillation, which means you have mitral valve stenosis, only VKA are indicated, but the majority of the mitral clip patients are actually MR patients. So you do not have this problem. Data we have is mainly from retrospective studies such as this one, which is very recent. It's data about real world with more than 1,000 patients between 2014 and 2018. And it showed that more than 1/3 of the patients received an oral anticoagulant, mainly DOAC. 22% received antiplatelet monotherapy, 12% dual antiplatelet therapy, only 6% triple antithrombotic therapy, which means oral anticoagulation plus aspirin plus clopidogrel. And nota bene that 20% had no antiplatelet or anticoagulation therapy at all, which led to an increase of all-cause mortality by 3.48 hazard ratio. TriClip is a device that has not yet been approved. There is those devices such as TriClip in image 1, TriCalc in image 2 are only in examining studies in trials. Off-label, we use MatraClip device in the tricuspid valve for severe regurgitation. There are no data for antithrombotics. We only extrapolate data from MatraClip trials or guidelines for surgical tricuspid valve repair. The indicating therapy is VKA with an INR target 3 to 3.5 or even higher due to the lower velocities in right circulation at least for 6 months, and even in the absence of atrial fibrillation. In congenital pulmonary valve stenosis, there is one approved valve, it's the Melody valve. It is used off-label for small mitral valve annulus. You do not require standard anticoagulant therapy, but if the patient also have atrial fibrillation, you have to give by VKA antagonist since it is a congenital heart disease valvulopathy. As patients grow older and they have increased survival, more and more we're going to face deterioration of valves, and we have to put valve in valve, valve in ring, or valve in valve. There is a lack of data on the management of antithrombotic therapy after implantation of transcatheter atrial biological heart valve disease, but the current practice is to give for 3 months VKA commonly. The largest amount of evidence regarding mitral valve in valve and valve in ring is derived from observational studies using valves that were originally designed for TAVI, mainly with a balloon expandable sapien. There are no randomized clinical trials, only observational studies with 2 patients, and mainly they examined VKA plus or minus aspirin irrespective of AF. We have no data about DOACs, and we have to know that up to 2 years, there is a 14.4% risk for thrombosis. So there is an unmet need to find the optimum antithrombotic therapy for these patients. Left atrial appendage occlusion devices are not actually valve, but it is a xeno device, and you have to know about the combination of the therapy. It is driven by the type of the device. If you have a Watchman device with high bleeding risk or quadra indication, you have to give dual antiplatelet therapy, aspirin and clopidogrel, for 1 to 6 months, followed by ASA alone. If the bleeding risk is low or the ischemic risk is high, for 45 days, we give aspirin and oral anticoagulation, mainly VKA antagonist. And after that, until 6 months, you have to give aspirin and clopidogrel. And thereafter, for more than 6 months, aspirin. With the Appledger device, in high bleeding risk, again, you give dual antiplatelet therapy for 3 months. And if the bleeding risk is low, you give it prolonged up to 6 months. So you have a lot of factors that affect the need of the personalized antithrombotic therapy. You have patient-related factors, the advanced age, the dysfunction of the left or the right ventricular, the suboptimal anticoagulation, the atrial fibrillation or prior thrombotic events, comorbidities, hypercoagulate state such as antiphospholipid syndrome or cancer. You have factors related to the procedure such as the position of the valve, if there is interaction between the bifrostasis mismatch and valve, the size, design, and material of the valve, the modality of implantation, the mechanism of anchoring, and of course, when you have valve in rig or in mat. And this creates a huge Gordian knot. Tips for dosing. The combination of OAC and ASA with potent P2Y12 inhibitors is not the preferred. The Apixaban and rivaroxaban are given with a lower acceptable dose when I have it in combo. Apixaban is given a full dose with one in combo with clopidogrel, but that was the trial design. You may adjust the doses based on GFR. You have to regularly reassess the indication of OAC and the appropriate dose. There's a mnemonic rule that you divide GFR by 10, and this is the months that you have to reevaluate the patient. You may combine VKA with aspirin or clopidogrel, but with a lower INR target, and DOAC with aspirin or clopidogrel. You cannot combine VKA with ticagrelor and prasugrel or DOAC with prasugrel, and you may not combine DOAC with ticagrelor. When you have to give combo of anticoagulants and antiplatelets, the minimum accepted duration is for triple combination 1 week up to 1 month, and for dual 6 months up to 1 year. There's a lack of robust data. More of the evidence are B or C, except for mechanical valves. You need to know more about the clinical benefit of more potent agents. We have to know more about the optimum combo and duration, the usage of DOACs, post-mitral clip or tri-clip, etc., and results beyond 2 years. Some examples. We have a TAVI in a 75-year-old patient with GFR 43 and other fibrillation and history of stable coronary artery disease. Then apixaban monotherapy up to age of 80 is the preferred therapy, and after that, the reduced dose, or until the GFR is lower than 30. If you have a TAV in a 70-year-old patient with a good creatinine clearance, plus non-STEMI with PCI VRCA 2 months before, you have to give dual antibiotic therapy, such as aspirin and clopidogrel, for another 10 months, and then lifelong aspirin. If in this patient you have also atrial fibrillation, you may give dabigatran 110 mg BID plus clopidogrel up to 12 months, and then dabigatran in full dose lifelong. If you have a mitral clip without atrial fibrillation but coronary artery disease, for stable coronary artery disease, you give aspirin and clopidogrel for 6 months and then aspirin lifelong. But if you have atrial fibrillation, then you have to change it to VKA lifelong plus aspirin for 1 week plus clopidogrel for 6 months. And remembering that during the combo period, the INRs will be lower 1.8 to 2.2. The less is more, but the tailored is the merrier concerning the number of drugs and the duration. Regular monitoring, reassessment of the need of a combination and the time window of the dual or triple antithrombotic therapy. Monitor GFR regularly. Overdose is as bad as underdose, and you have to avoid risk factors that increase the bleeding profile of the patient, such as NSAIDs and alcohol. My goal was to transverse this to this, and I would like to thank you very much for the attention. If you have